All right. Hello, everyone. Thank you for joining us in the third webinar of this series, The Journey to Health Equity, a Roadmap for Rural Hospitals. My name is Amanda Trish. I am the Rural Health Development Coordinator at Wellhead, Louisiana. Today, I'm going to add Dr. Bionami's bio to the chat just to save us a couple of minutes. And I'll go ahead and hand it over to you, Doctor. Thank you so much.
Well, good morning, everyone. Thank you, Amanda, and Happy New Year to everyone. I hope that your 2025 is off to a great start. We're in the ninth day, so we're thankful for that. I'm excited about our third webinar. I'm excited about what we've already done and shared, and so I'm looking forward to another great session. So this is our Journey to Health Equity, a roadmap for rural hospitals. And one of the things that I decided to do for webinar number 3 is to do a little review recap of the Centers for Medicare and Medicaid Services screening for social drivers of health measures. I wanted to make sure on webinar 2 that we had enough time for our great guest speaker that shared, Kathy Terry from West Feliciana Hospital, the community chairperson and business development leader, that shared a little bit of their journey in terms of their health equity and developing a health equity plan and implementing the plan. I thought it was so helpful, but I felt like we needed to kind of just recap a little bit on those social drivers of health measures. And I also wanted to look at collecting assessment data for social drivers of health. What are health-related social needs? What kind of tools are out there and available? I'm going to share a couple of tools with you. And then lastly, we're going to talk about the Joint Commission standards to reduce health disparities. So our objectives, I always like to start with objectives to make sure that we're sticking to what we're saying we want to accomplish on this webinar. In terms of our social drivers of health measures, we're going to just review a few of those concepts, not spend a lot of time on it, but just to recap a little bit. Share examples of evidence-based tools for collecting these social drivers of health-related social needs, and to also just discuss briefly a little bit about Z codes as a part of the ICD-10 CM classification of document non-medical factors that affect health. And then with our Joint Commission strategy to reduce health disparities, we're going to describe the purpose of the Joint Commission's R3 report, and that information was listed in your resource for webinar 2, and it's also for webinar 3, and its contribution to improving patient safety and quality of care by promoting evidence-based standards. And secondly, to provide an overview of the key requirements outlined in the R3 report, highlighting the evidence and rationale behind each standard and its implications for critical access hospitals. And I like the idea that we're having rationale, because I think whenever we're working with gathering information, collecting data, that we have to always understand what's the rationale behind what we're doing. So just to go back to our screening for social drivers of health measure, we know that CMS included these measures, and now these measures are mandatory. And we know that all hospitals participating in the Hospital Inpatient Quality Program are required to report on these measures. And we're looking at, in terms of the number of patients admitted to the hospital who are 18 years or older at the time of admission and are screened for all of the 5 health-related social needs. And what are those health-related social needs? They are identified as food insecurity, and food insecurity is identified as having limited or uncertain access to adequate quality and quantity of food at the household level. And we were talking about, so it's not just the quantity of food, because we can have a lot of food that is not nutritious, that's not good for us. So it's also the quality of the food that's available to the household. Housing instability or insecurity. What is that? That's the multiple conditions ranging from the inability to pay rent or mortgage, frequent changes in residence, including temporary stays with friends and relatives, living in crowded conditions, and actual lack of sheltered housing in which an individual does not have a personal residence. So homelessness falls under that. Transportation needs. Unmet needs include limitations that impede transportation to destinations required for all aspects of daily living. So it's not just transportation to our doctor's visit, it can be transportation to work as well, or being able to take our children to needed places. But having proper transportation. Then utility difficulties. That includes inavailability of electricity, water, oil, gas services. And these are associated with housing as well as with food insecurity. If we have no electricity, if we have no gas, we lose the ability to prepare meals for our family. And then there's interpersonal safety. Interpersonal safety has to do with intimate partner abuse, violent child abuse, and elder abuse. So you can see that these are the health-related social needs that CMS has identified and said that, the healthcare facilities must, the rural health hospitals must, the critical access hospitals must assess their clients for. And so it's so important when I read the descriptions of those that we're consistent throughout, the facility, whoever is collecting the data, that has a good understanding, because patients will not, put the information in a way that always fits into a certain box. We have to be able to look at the information and then come up with that health-related social need that is a barrier for our patients. And then in terms of the denominator, the total number of patients admitted to the hospital who are 18 years old or older on the date they're admitted. So let's say within a 3-month period, your facility admitted 100 patients that were 18 years or older, and 90 of those patients were assessed for the 5 health-related social needs, which means that 10 were not assessed. So you had a 90% of your patients actually were assessed for those health-related social needs. Now you have exclusions. There are patients who opt out of being screened, and patients have the right to opt out of being screened. We have a concern in patients sometimes, and we have to realize that in terms of trusting of our healthcare facilities, trusting of how are you going to use this information? Why are you asking this information? We know what our goal is, or what the health facilities goal is to improve, to provide resources that would help to improve healthcare outcomes, to address that health equity. But patients may not always understand that, so they have the right to opt out. Patients who aren't able to complete the screening themselves, if it's a patient that's an elderly patient that's experiencing dementia and they can't complete the screening, and there's no family member or guardian that is present that is able to complete the screening, so those patients are excluded. So let's say if you had 100 patients admitted and 2 patients were excluded, then your denominator would then be 98, and your numerator would be the number of patients that were screened for all 5 of those social needs. So that's the first process in terms of screening for social drivers of health measure. And then we have our second, screen positive rate. So when we're screening these patients, and whatever process that's being used by your facility to actually collect this data to screen these patients, and we're going to try and find out a little bit more about that in one of our poll questions next. This information provides the percentage of patients admitted for an inpatient hospital stay who are 18 years of age or older on the date of admission, and they were screened for all 5 of the health-related social needs, not just one. We can't say, oh, well, they just responded to one. No, they have to be screened for all 5. And screening for all 5 would be for 4 of them that they said they had no problem, but for 1 of them they did, but they were assessed for all 5. And we talked about what those health-related social needs are. So the numerator now becomes the total number of patients 18 years or older who received screening for all 5 of health-related social needs, and who screened positive for having a need in 1 or more of the identified health-related social needs. So you may have had a patient that, screened for all the positive, said, yes, I have problems with having adequate food for my household. or I have transportation needs. I can't get back and forth to work or to my doctor's appointment. So that patient may have screened positive for only 2, but they were assessed for all 5. So your denominator now becomes the number of patients admitted for an inpatient stay who are 18 years or older on the date of admission and were screened for all 5. So what you have now, let's say, for instance, you had from the previous one, we screened 100 patients. And let's say if we screened 100 patients for all 5 of the health-related social needs. And then we had 80 patients that screened positive for 1 or more of the social needs. Okay, so we had 80% of our patients were screened positive for those health-related social needs. But now what we have to do is that we're going to develop results. We're going to measure each one of those health-related social needs separately, one of each for each of those domains. So for instance, let's say of those 90 or 80 patients, and we'll go with the 90. Of those 90 patients, then that were screened, and 10 of them said that they had problems with transportation. So you would determine the percentage for the screen positive rate for transportation. So if we had, and we'll make the math easy, we'll say 100 patients were screened for all 5 of the health-related social needs. And of those 100 patients, 10 patients said that I have problems with transportation. So that means 10 out of 100 said that, hey, 10% of those patients said that I have problems with transportation. So then you may come up again, you may see that, hey, another group said that I have problems with housing insecurity. I can't pay my rent. I'm having to move from one place to another because I don't have the finances to pay the rent or the mortgage. And that may be, 15 out of 100 of patients. So that's 15% screen positive rate. So you can use this information. So this is what your screen positive rate, but also always go back to how do I use this information? So you can use this information to determine, again, those areas in which your patient population screen positive, their screen positive rate, what's the highest percentage? The majority of the patients that have been screened within your facility is transportation. The highest percent of having problems with transportation is the highest percent having problems with food insecurity. You can use that information to really help you to decide, help you to move forward in terms of where should we place our limited resources? What health-related social need is presenting a barrier for the majority of the patients that we service in our facility. So that's how you can use this data. Collecting the data is extremely important, but utilizing the data is also more important. Okay, so now I'm going to ask you a question, a poll question. And I think it's very important. These questions tend to help us, to determine how can Well-Ahead develop technical assistance services that would best benefit you. So how is your rural hospital, critical access hospital, currently collecting social determinants of health, health-related social needs data? Is it directly through electronic health records? Is it through screening forms? Is it through clinical notes? Is it through other methods? If you can complete that for us. Okay, it appears that 91% directly into electronic health records. And then we have screening forms. Okay. It looks like electronic health records is the primary method in which this data is currently being collected. Okay, thank you very much. Thank you. 93%, okay. So we're keeping this data, we're keeping this information because it's going to help us as we move forward. All right. Thank you for participating. Okay, now I have another poll question that takes us a little bit deeper. Another poll question. Who is responsible for collecting the social determinants of health, health-related social needs data at your healthcare facility? And ask select all that apply because it may be multiple people that are responsible. We have options for the health assistant, a nurse practitioner, nurses, a registered nurse, maybe a licensed practical nurse, social worker, a community health worker, case manager, patient navigator, and I feel like I should have put other there. So if there's other individuals that assigned within your facility that are collecting this data, please put that in the chat for us because we want to have that information as well. Okay, but based on our poll, it looks like the majority, I think looks like what, 75% that's being collected by the nurse, and then we followed by the case manager, then the social worker, community health worker, healthcare provider. Thank you very much. This is extremely helpful information because this helps us, and we're going to talk more about the training of those that are collecting the data, providing appropriate and adequate training for those that are collecting the data. Okay. Thank you very much. We're going to definitely hold on to these results. Okay. All righty. Next, I just wanted to add just a little bit for sharing to talk about health information exchange. And I think it's absolutely great that, this is very important information because the majority of those that are on the webinar today are collecting their health-related social needs, social drivers of health information electronically. And so you're very much aware, it's like I'm talking to the choir. But this health information exchange allows healthcare professionals and patients to appropriately access and securely share patients' medical information. So you all already know all of that. I just wanted to make sure that we understood the benefits of this access and confidentiality, share patients' vital medical history. A patient is seen at one healthcare facility and that information can be shared with another health facility, or even when we're talking about health-related social needs, if that information is gathered at one facility, then that is automatically you can retrieve that information at maybe it's your rural health hospital, or your critical access hospital. Provide safe and more effective care tailored to patients' unique medical needs. Patients can use HIE to access and securely share their medical information electronically with healthcare providers. For instance, I'm on MyChart, and I frequently use the information on MyChart in order to submit information to my patients. Like I'll do a blood pressure log for myself, and I'll send it to my doctor. Or if I have to submit any outside tests, COVID results, because they don't have the Moderna at their particular clinic, then I can submit that. So I really appreciate, the use of MyChart. But I've had some associates that, based on the healthcare facility, the healthcare system, the two systems did not communicate with each other. So that did present a barrier. So having all systems that communicate with each other that would be ideal. And then you have organizational administrative benefits, minimize administrative burdens, of course, reduce paperwork and storage costs, and then, of course, telehealth cost efficiency in terms of, ability to participate in telehealth and that primary healthcare provider or that healthcare provider being able to have access to a person's medical information. And then I wanted to share about the health information exchange organizations, which I think, especially larger hospitals are participating in, and probably some of our critical access hospitals and rural hospitals refers to local, regional, or state entities that facilitate the secure electronic sharing of patient information. They actually serve as like a central hub of exchanging patient information. And examples of those are our Cerner Corporation, Epic Corporation. And I also put a source at the end of that. that the National Rural Health Information Technology Coalition online at their website, they have a great video that talks about the relationship between health information exchange and health equity and the gathering of information and data related to the health-related social needs, social drivers of health. So I just wanted to mention that. So now we have 2 more poll questions. We're not going to wear you out with the poll questions, I promise. These are the last 2. But again, we're gathering information from you. And this poll question has to do with, okay. Does your rural hospital, critical access hospital use a health information exchange organization to share or access patient information? And the answer is yes, no, or unsure. And if you're unsure, that's fine. That's absolutely fine. Does your rural hospital, critical access hospital, use health information exchange organization to share or access patient health information? And it looks like a little over half said yes, 15% no, and 31% unsure. Okay, awesome. It's great information. Okay. And our last poll question for this webinar: to what extent does your rural hospital, critical access hospital, use HIE organizations for patient data exchange? Occasionally, regularly, and extensively. Okay. But we have one. Okay, let's see. That's occasionally, regularly, extensively. To what extent does your rural hospital use HIE organizations for patient data exchange? Right, it looks like we have 71%, 5 out of 7 that said regularly. Occasionally, we have 29%. And no one extensively at this time. But the regular is pretty good. So thank you for sharing that information. This is extremely helpful as we move forward, extremely helpful. Okay. So now we're going to just look at some challenges related to social drivers of health-related social needs. And I'm using both of those terms, you all, because they're so very similar. And for one situation, you may be using the term social drivers of health. For another situation, you may be using the term health-related social needs. Early on in webinar 1, we talked about how there's difference between social determinants of health, social drivers of health, and health-related social needs. But I think these 2 terminologies that we're using are very similar in terms of what how we're collecting the data, and they're being used by the 2 different organizations, CMS and the Joint Commission. So what are these challenges? No single standardized coding system. That's the first challenge. And while the ICD-10 Z codes are used to address social drivers of health-related social needs, they may not be comprehensive enough or consistently applied across different healthcare settings, leading to variability in data interpretation. And that's key, especially, and we're going to look at some of the Z codes in just a few minutes, but we have to make sure that we're interpreting, understanding what these codes mean, what these when we're assessing the health-related social needs, making sure that it's easily understood, that we're all on the same page, which is why it's so important that this be for all, especially those that are collecting the data, that there be a consensus among those individuals, those entities, even those facilities that are collecting the data on what it is exactly that we mean when we're putting in this particular Z code. So the solution would be to create a consistent framework for capturing and documenting social drivers of health or health-related social needs information across different healthcare settings. So we have to be able to communicate with one another. And then there's your issue with data quality. in terms of incomplete or inaccurate information due to reliance on patient self-reporting, because in some circumstances, this is patients completing some type of questionnaire survey, and so they will be self-reporting. Lack of structured screening tools. It's so important that you use a tool that is evidence-based, which means that that tool has been vetted for credibility and validity in terms of its usage. And also inconsistent data collection methods. How is we talked about, there are some very sensitive items, questions that are being asked of our patients. And it's very important that we are very culturally sensitive, cultural humility, really take into consideration how these questions, the asking of these questions are impacting our patients. Solution: provide comprehensive training for healthcare providers on how to effectively screen for and document social drivers of health-related social needs data. And so training is absolutely essential. We can't just give these items to an individual and say, hey, gather this information from the patient. There's a way to ask these questions, and sometimes the patients may not trust you. Sometimes the patients may not understand. I went to the doctor just earlier this week, and I think it was the medical assistant that did the initial assessment. And the question was, have you been depressed over the last month? Well, I know what depression means, but every person may not understand that what they've been feeling emotionally, psychologically is depression. So again, to really get at good, high quality data, we have to be educated on how to ask these questions. Okay, next we have integration of challenges with electronic health record systems. Again, difficulty in integrating social drivers of health data into existing electronic health records. And that could be a concern, a significant concern, making it challenging to access and utilize this information for clinical decision-making. If we're collecting this data, it's being input into an electronic health record, but yet we cannot access the data, then all of our work is for naught. It's so important that there's communication, there's relationship between those that are not only collecting the data, but also our HIE, human resources, IT, human resources, that we're able to working with us to be able to retrieve the data and retrieve the data in a way that can be easily analyzed. Also, potential concerns regarding patient privacy concerns. And again, we talked about the patient being concerned about, how are you going to use this data? And we know why we're collecting the data, because we want to help. We're addressing health equity. We want to make sure we can provide resources that can assist you with these non-medical needs that are impacting your health care. And then time constraints. It takes time. It was very easy for that person to come in and just ask, have you experienced depression within the last month? And I say no, and they put a check mark no. But it takes a little bit more than that to really to get at some of these answers. But it takes time, and time is very valuable, especially within our healthcare system and for our healthcare providers. And so we have to make it, and the last one says lack of reimbursement incentives. We have to provide those reimbursement incentives that encourage our healthcare providers to collect this data. And we also have to be able to share with them how the data is being used and what's the impact on the interventions that we're doing in terms of utilizing this data to improve healthcare outcomes. So these are some of the challenges. And now I wanted to share with you just very briefly some of the evidence-based tools that are out there. I'm just going to share two with you. And that first tool, this is the tool from CMS, and it's the Accountable Health Communities Health-Related Social Needs Screening Tool Core Questions. And all of these questions get at answers to those health-related social needs. Remember those 5 health-related social needs. And I won't go over all of them, but you can see in terms of living situation, what is your living situation today? The first item says, I have a steady place to live. Well, that automatically tells you that that's not a barrier for that person. But if the person checks, I have a place to live today, but I'm worried about losing it in the future, or I do not have a steady place to live, I'm temporarily staying with others in a hotel or shelter, living outside on the street, on a beach, in a car, abandoned building, bus or train station, or in a park. So anything that's underlined lets you know that that's screen positive rate. That's a barrier for that patient in terms of their health-related social needs. Now, that may be the only question that your facility decides to select in terms of to determine living situation. But in this particular two, they went a step further and they asked a question about, do you have problems with any of the following? Again, related to living and housing situation. Pests such as bugs, ants, or mice, mold, lead paint or pipes, lack of heat, oven or stove not working, smoke detectors missing or not working, water leaks, none of the above. So if the person says that they don't have a smoke detector, then ideally a situation would be that, hey, we have community resources we could hook you up with. Our fire department gives free smoke detectors and they'll even come in and put it in for you. But let's say if a patient comes in with asthma and they're telling you they're living in a place where there's mold and lead paint in the pipes, then those are situations that will definitely impact their health. So those are things. So this is additional information that can help in terms of providing resources or attempting to provide resources to help those patients. But you can see in this particular document, again, you probably have seen this before. It's cited in the resource and references on the PowerPoint, but they address all of the health-related social needs. And this just goes on to talk about safety. How often does anyone, including family and friends, insult or talk down to you? How often does anyone, including family and friends, threaten you with harm? So those are those interpersonal health-related social needs. And then I'm not sure how many are familiar with the Prepare tool. There's been extensive research on this particular tool. Again, these are examples of tools that can be used to collect data related to the health-related social needs of social drivers of health. And this is the Prepare stands for Protocol for Responding to and Assessing Patients' Assets, Risk, and Experience. And it's a national standardized patient risk assessment tool designed to engage patients in assessing and addressing social drivers of health. So again, they have some similar questions, maybe asked in a little different way. And so for your facility, as you're preparing, you probably have already done that for all of you all that are collected this information. But for instance, they ask, what is your housing situation today? I have housing. I do not have housing, staying with others in a hotel or a shelter, living outside, or I choose not to answer this question. If the person says, I choose not to answer this question, then that person is opting out of that assessment. Okay. Now I just want to share just a little brief case study that came from Prepare, just to show you how this information can be used. Not only is it cost effective for the healthcare facility, as well as improving healthcare outcomes for the patients. A health center in Missouri calculated the number of missed appointments and how much money that was costing their organization. After they administered the Prepare with their population, with their patient population, they administered the Prepare. They found that 1 in 4 of their patients had transportation barriers. So it didn't have to be to Prepare. It could have been the CMS tool. It could have been, whatever tool your hospital is using. You may have had the ability to determine that what was the biggest barrier for your patients in returning for their follow-up appointments. So they found that 1 in 4 of their patients had transportation barriers. With this knowledge, they implemented a couple of transportation interventions and reduced their no-show rate by 50%, which led to a significant increase in revenue for the organization and better care for their patients. So this is the kind of information that can be generated through your health equity plan, through the implementation of your health equity plan, through evaluation of the evaluation of the findings obtained with your health equity plan. And this is the kind of information that their C-suite would love to hear. How can it save our institution money? And on top of that, it's improving healthcare outcomes for our patient. So and how the whole point of those health-related social needs that impact health. I also wanted us to briefly look at some of the Z codes that we talked about that are in the ICD-10 that really address those non-medical needs that we've been talking about, those health-related social needs, social drivers of health. We know that as of 2024, the CMS requires hospitals that accept Medicare patients to, again, assess for those social determinants of health, social drivers of health. We've already addressed that. And then we see here that the Z codes contribute to a comprehensive understanding of a patient's health and as it relates to those non-disease factors that influence well-being. So the Z codes capture those health-related social needs, those social drivers of health. And then what we find is that Z codes identify a range of issues related to, but not limited to, preventative health services, education, literacy. So it goes beyond those 5 that were identified by CMS. Employment, housing, the ability to obtain adequate amounts of food, occupational exposure to toxic agents, and many more. The Z codes that are currently in place are comprehensive, but each year, I think it's each April and October, these Z codes may be updated. And finally, the social drivers of health or health-related social needs are primarily captured by ICD-10 CM codes from Z55 to Z65. While social drivers of health Z codes, they've been previously underutilized, but they're being utilized more and more. And this is impacting our ability to actually retrieve this information through our electronic health records and utilize it in terms of identifying what are the priority areas that we need to address for our patient population. And remember, each community, each critical access hospital, each rural hospital, your community may be different from the next community. Your community is unique. And I just wanted to share this just little infographic on the social determinants of health and data with ICD-10 CM codes. I thought it was very informative. One of the things that I wanted to point out, though, is that here in the lower, the blue item, it says, coding professionals may utilize documentation of social information from social workers, community health workers, case managers, or nurses if their documentation is included in the official medical record. So this is key. The documentation must be included in the official medical record. It says social drivers of health information can be collected through person-provider interaction or self-reported as long as it is signed off, and this is key, signed off on and incorporated into the medical record by a clinician or provider. It is important to screen for social drivers of health information at each healthcare encounter to understand circumstances that may have changed in the patient's status. So it's not that we just screen for this one time. This is an ongoing process because that's how we determine improvement. Where is our measuring stick? Are we getting better? Are we having fewer patients missing their appointments? So it's very important to follow through on this information. Okay, and then this our next one deals with, just share some of the Z code categories and new codes. And you can see that there's subcategories under some of these. You have problems related to education and literacy. One is considered less than a high school diploma. And then problems related to health literacy. That's new. And so in terms of problems related to health literacy, there may be different problems associated with that. And so I would imagine that in the future, there may be some subcategories there as well. Problems related to employment and unemployment, occupational exposure to risk factors, problems related to physical environment, inadequate drinking water supply, basic services unavailable in physical environment. Then we have problems related to housing and economic circumstances. Homelessness falls under this category. Then we have inadequate housing environmental temperature, and other inadequate housing that may not fit under a certain category. In this particular one, you also have your transportation insecurity. That's Z59.82. You have problems related to social environment is another category. Problems related to upbringing, where child in custody of non-parental relative. You have personal history of child financial abuse. And you can see, again, we're screening for these health-related social needs, but as you can see, it's very sensitive information. We have other problems related to primary support group, including family circumstances, problems related to certain psychosocial circumstances. So again, even though we have quite a number of Z codes, you can see where there is room for subjective interpretation. And so that's what we have to get away from as much as we possible, is that subjective interpretation. Okay, now we're going to take some time and go through that Joint Commission strategy to reduce health disparities. So we've talked about, the whole key here is developing our health equity plan on our health equity plan journey. So we all understand that health equity means that we want everyone to have access to high quality health care and have the ability to have a healthy life, a healthy lifestyle, healthy life. We want to reduce healthcare disparities. We want to reduce health inequities. So all of these processes are heading toward that. So first of all, in order to do that, we have to assess for what those social drivers of health are. What are those health-related social needs that we're talking about that are not medical? And we said over 50% of those of these types of needs impact health outcomes. And so now the Joint Commission strategy is to reduce, again, to reduce health disparities. But what the Joint Commission has done is says it aims to decrease disparities by setting rigorous standards for healthcare organizations, requiring them to actively identify and address disparities in care delivery across different patient populations, including through data collection, cultural competency training, and promoting patient-centered care, all while offering a voluntary, and this part is voluntary, healthcare equity certification for organizations actively working to close gaps in access and quality of care across diverse groups. So I want to really stress here that all we've been discussing is leading toward the very common goal. And so even though CMS requires one thing, Joint Commission requires, but they're both are very much integrated, interrelated. And so within this health equity plan, health disparity plan, whatever you want to call it, you're going to be meeting, if you incorporate these things, you're going to be meeting the guidelines and the standards for each one. So I don't want people to feel, oh, I have to do this and I have to do this for this one. No, let's see how we can integrate these and be able to respond, because our goal is the common goal is to decrease health disparities, improve health equity. So R3 report issue, and I have that resource again in your documentation. It's a great read, requirement, rationale, and reference in terms of guidelines and how you move forward with these R3 report essential elements of performance. There are 6 elements of performance that Joint Commission says are including critical access hospitals are required to implement. The first is identify an individual to lead activities to improve health equity. Second is to assess the patient's health-related social needs. 3 is to analyze quality and safety data to identify disparities. 4, develop an action plan to improve health equity. 5 is to take action when the organization does not meet the goals in the action plan. And lastly, inform key stakeholders about progress to improve health equity. To me, this sounds like a lot what we've already been talking about. From developing our health equity plan to looking at those social drivers of health, those that are putting a plan, how we're going to collect this information, how we're going to develop this team. So again, many commonalities. So I want everyone to remain as calm as possible because there's ways to link this information and we can meet everyone's criteria, but the ultimate goal has to be that of improving health equity. So leadership, we've talked about leadership in our first webinar. Management level leadership, physician leadership, team leadership. This person in leadership has to be a person that's well respected, that has some influence within the healthcare facility. And what they found in the past, and we've talked about this, that the lack of such leadership is frequently linked to the failure of quality improvement efforts. So it would be linked to the failure of your health equity plan. So you have to, again, really be strategic about who will be leading this team, because it can't be one individual person. I want to make sure that's well known. It has to be a leader, but a leader that has a team. Identify an individual to lead the organization activities to improve health care equity establishes a clear line of accountability and ensures that staff have the support necessary to implement successful initiatives. And we mentioned before that this person must be communicating with those that are in the C-suite. So our next element, essential element, would be assessment of health-related social needs. So I think we've been talking about that. I think we've been talking about how do we collect data? How do we assess for this and for our health-related social needs? Again, maybe a little different verbiage, but we're doing the same thing. Growing body of research supports the value of identifying and addressing specific health-related social needs. We've talked about that. Critical access hospital must assess. We've talked about that. Example of health-related social needs that include access to transportation, difficulty paying for prescriptions or medical bills, education literacy, food insecurity, housing insecurity. Now, currently it says health-related social needs may be identified for a representative sample of patients or for all the patients. And this is, remember, this is Joint Commission. Our next element of performance is analysis of quality and safety data to identify disparities. So we've collected the data. We've collected the data using valid tools, valid instruments, credible instruments. The data has been input into our electronic health records using Z codes. May not always be, but using Z codes if that's the process that we're using. And now we're retrieving that data from our electronic health records, working with our IT people. And now, though, it says that we're going to analyze the data, but it's introducing a next step. The critical access hospital must identify healthcare disparities in its patient population by stratifying, a new term, quality and safety data using the sociodemographic characteristics of the patients served by the critical access hospitals. So we've collected that health-related social needs data, that social drivers of health data, but now we must take that data and stratify it according to certain sociodemographic characteristics. And they've given you examples. Age could be one. Gender could be one, language could be one, race and ethnicity could be one. So these are just examples of how that information can be stratified. It is essential for critical access hospitals to conduct analysis to understand the specific disparities that may exist in their institution. This process begins with stratifying existing measures. Critical access hospitals must determine which sociodemographic characteristics are used for stratification analysis. And this comes from your data, from your healthcare facility, from your community health needs assessment, from your social drivers of needs measures. You're going to look at this data, and for instance, you may say that problems with transportation may be one of those health-related social needs. And then you're going to look at and stratify it according to age, gender, preferred language. If a large percentage of your population that comes to the facility are the elderly, then you may want to stratify it according to age. And you may see that 60% of the elderly population are reporting that they have difficulty with transportation to getting back and forth to their medical appointments. That gives you a lot of information. Then you know where the resources are needed. If you have a health disparity where you have, let's say, high blood pressure, and you stratify that information because it's based on the literature, based on whatever, your patient population, that you have a large African-American population. And you see that, 40% of the patients that come to your facility have a diagnosis of high blood pressure. And when you did that assessment, that health-related social needs assessment, you found that many of them, a large percentage of those patients, those Black African-American patients diagnosed with high blood pressure, have difficulty buying their blood pressure medication. So then we can begin to get with our resources, our community resources, this team of community people that we have, and see how can we begin to address that? How can we assist this population in getting the medication, being able to access the medications that they need to control their blood pressure? Again, I want everyone to remember, this is not just on the hospital. The hospital is collecting this data. The hospital may be even being an important leader in this process, but the community is essential because that's where your resources are going to come from when trying to address these health-related social needs. So involving your community, but stratifying this data in terms of these sociodemographic characteristics helps you to pinpoint and focus the resources on where they're most needed to improve healthcare outcomes. Essential elements of performance, develop an action plan to improve health equity. We've been talking about that all along. Develop a health equity plan. The critical access hospital will develop an action plan that defines the healthcare disparity and specific populations of focus, the organization's improvement goal, the strategies and resources needed to achieve the goal, and the process that we will use to monitor and report the progress. Healthcare organizations are only required to address one topic. This is Joint Commission, only required to address one topic, even if they identify multiple disparities. So the topic that you, in terms of meeting Joint Commission, it could be lifted right out of your health equity plan, or just point to, this is the disparity that we're addressing. This is the socioeconomic, sociodemographic group that we're seeing the greatest prevalence. This is the major health-related social need barrier that's impeding the improved health outcomes. And these are the interventions that we're doing. This is the strategy that we've developed to address this major health-related social need that's related to this health disparity. And in doing that, and you're going to see next, so you develop this action plan based on all the information that you've collected, and everything falls in line. So, you're working with what CMS has said, you're working with what Joint Commission, but the whole goal is that this is being put into our health equity plan. And then number 5, taking action when this critical access hospital does not meet the goals in its action plan. Now, in order how do you know you're not meeting the goal? That means you have to go back and evaluate this whole process. That's why having a leader, a health equity leader, or whatever you want to call that person, and their team is so important, because you have to have follow through. We cannot just develop a plan, say, hey, I met the goal, we developed a plan. Hey, we met the goal, we developed an intervention. This is our intervention. How well is the intervention being executed, and what are the outcomes as it relates to that intervention? So you have to review quality and safety metrics, collecting feedback from patients about new services, interventions, and really determining the effectiveness of this service. And if you're based on your plan, your intervention, they're not being effective, then you got to go back to the drawing board and talk to people and say, hey, why do you think this is not being effective? And then revise the plan accordingly. And then lastly, informing key stakeholders about progress to improve health equity. This is essential. If you've gone through all of this work, you've developed this plan, and you're seeing great outcomes as it relates to this plan, you need to shout it to the world. You need to shout it to all of the people within your organization, because they have to be a whole part of this process. They have to be partners within this process. And you need to shout it to your C-suite. You need to shout it to the community. Call a big community gathering and say, this is what we've done as a community together. And keeping in mind that this is not, the Joint Commission may have said, hey, you just addressed one disparity. That's all we require. But within your community, there's many more things we can address. So then identify what the next is, because this is your patients to know that, hey, our rural hospital truly cares about us, but we're a part of this whole process. So again, shout it to the roof, all the successes that you're making. So now I have opportunity for questions. I apologize, I don't have much time left. There's a lot of information, but if anyone has any specific questions, please, I'm available. And even if you don't have time here, you can you can email me, you can email Well Ahead, and they'll get in touch with me. But I'd love to speak with you, and if there's any way that I can assist you. But believe me, when you're completing that evaluation, that brief evaluation, we're taking all of the information into consideration and trying our best to address whatever issues you may have. These are your resources, and all of the resources that I've shared with you, they are available on this list. And because there are many, many, many resources out there that are very helpful in this process. So our next webinar will be on February 13th. And we'll be engaging community members. It'll be focused on engaging community members in rural health equity journey. And this is where we talked about, hey, this is not, the hospital cannot do this by yourself. You have to have that community involved. You have to have, all those entities and organizations within the community involved in this process, but they have to be made aware of that. They have to be made aware of what's happening, why we're doing this. So it's really a lot of sharing of information. And the assignment that I'd like to share with you is that for you to come back prepared to share an example of a community engagement effort by your rural hospital. We're going to hear from you at our next webinar, because we want to know what you're doing. And we also want to know what the barriers are that are preventing you from being able to really bring the community in and to engage the community in these efforts, because I know human resources is probably one of the biggest barriers, but we want to hear from you all next time. Thank you very much for this opportunity. I look forward to seeing you again in February, and please reach out. Brief evaluation, if you could scan the QR code, or if Amanda, if you could put the link in the chat for those that would just like to click on the link, that would be great. I don't see if there's any questions in the chat. Should I stop sharing, Amanda, or? Let's see.
I apologize. I couldn't find access to the link quickly enough, but I will send out the slides and the link and all of that in a follow-up email to all of the attendees.
Okay, sounds great. Sounds great.
Thank you so much, Dr. Bienemy.
Thank you, and thank you to everyone that came on today. We look forward again to seeing you in February. Have a great rest of your day.